Thank you, Barbara. Good morning. It's a real pleasure to engage in this activity. Matt and I have done this once before, I think probably maybe 7-8 years ago, and at that time I was in Canada, so it was an international debate. I think now it's a hometown derby that we're going to engage in. I have nothing of interest to disclose. When we talked about how we should proceed with this debate, there's many ways in which you could actually frame the question, and what we felt was the most interesting was to actually look at what about the evidence that currently exists for early therapy, because if you believe that the ductus is actually an issue of concern, logic would tell you that modification of this physiologic disturbance, earlier management should make a difference. As Barbara has pointed, the pendulum has swung from one extreme to another extreme, and in some respects that's good. It's got physicians to think more about a problem that was in the past simplified down into a dichotomous outcome, and over the last 10 to 15 years, we've seen fairly significant secular change away from medical and surgical therapy and an increase in the utility of conservative therapy. As Barbara has mentioned, it's very, very concerning that since 1963, long before I was born, this controversy has existed. And I think therein lies the key to the problem. Has the science been sufficiently detailed to help us answer the question? And my biggest concern is not that there are some PDAs that do not require therapy or that perhaps can be managed in a conservative manner, but actually the utility of the word conservative, which has been interpreted in many manners, some of which may be extreme. Part of the issue, as you can see in this picture here, is that we are fishing in a barren land and fishing in a very extreme and non-intelligent manner. And to be honest, we won't be very good fishermen if we don't have the right equipment, or know what is the right sea to fish in. Therein lies the crux of the issue. Matt's case is going to be built on the data from Jan Milliton's group that spontaneous closure occurs. The fundamental question for you to ask is exposure of more than 50% of babies less than 750 grams to a median of 50 days an acceptable risk? And the second question, we have no idea, how does spontaneous closure occur? Is it natural remodeling of the ductus, which may be something that's safe, or is there modulation of the pulmonary vascular bed, which is driving up your pulmonary vascular resistance, limiting the volume of flow across the ductus, allowing natural closure to occur by that mechanism? Therein lies a concern that we may be exposing babies to an unacceptable risk of deranged pulmonary vascular disease. My arguments are going to be based on the following. One, the trials of prophylactic and therapeutic use of nonsteroidals are flawed. Second, our clinical approach in the first week of life is limited. There are many people that believe that the ductus does not appear or have a role. Third, the way we have utilized echocardiography in the past is limited. And I will hopefully share with you that a much more comprehensive, thoughtful approach by hemodynamic consultants, by providing enhanced physiologic precision, will help us move forward. So Bill Bennett and Matt and others will say that if you look at the 67 plus trials and look at the relevant neonatal outcomes, there's no evidence of benefit. And based on the trials, he is correct. There is no evidence of benefit. The fundamental question, though, are these trials correctly designed to ask the question of interest? If we are to appraise this meta-analysis in an intelligent, logical manner as thoughtful physicians, firstly, was there diagnostic homogeneity, the role of the shunt? Second, was there standardization of how we defined hemodynamic significance, the relevance of the shunt? And thirdly, who were the control group? Kurt Duvall, very elegantly, about 5-6 years ago, published this important paper looking at how did we diagnose the problem, and it's highly, highly variable. In some cases, we didn't even mention. Some cases, it was just clinical assessment alone. And with respect to echocardiography, between studies, there was significant variation, with the only parameter that was consistent was PDA diameter. Did we consider the variable biological role of the ductus in these studies? And the answer is no. To understand the ductus, you need to understand that it's a physiologic continuum. In some patients, it has a normal transitional biological role. In others, it may be supportive. So if you close the ductus in someone with pulmonary hypertension, right or left heart dysfunction, this would not be a good thing. Did the trials sufficiently exclude these patients? The answer is no. What about the control group? This is from Willem de Bood's study a year ago in kind of anticipation of the Benedictus trial. More than 50% of the trials conducted to date the patients have received treatment in the control arm. Even including the recent PDA Tolerate trial, 63% of patients received therapy. Most interestingly, and we'll come back to this, is that even in the treatment arm, there was significant less refractory hypotension in the first week of life. Trials have been based on diameter, and diameter is intrinsically flawed for the following reasons. One, it depends on the operator. How skilled are they at the art of echocardiography? Two, how interested are they in the patient population? Thirdly, is the equipment good enough? And finally, did we properly geometrically assess the ductus? If you look at the reliability of conventional markers that might tell you something about the ductal shunt, what you can see is that the least reliable measurements are ductal diameter and the LA to AO ratio, which were the two measurements that formulated most of the trials conducted to date. Additional measures that will tell you something about the physiology were much more reliable. Secondly, to answer the question, and I apologize for the small text here, but if you're to look at the relationship between diameter and other parameters that give you insights into the degree of physiologic disturbance, what you can see is that the correlation values are incredibly low, suggesting that diameter on its own provides insufficient information to inform you about whether this is or this is not a significant shunt. And if you go back to basic core physiology, which was the core root of neonatology, Poiseuille's law, which determines flow across a vessel, is determined not just by diameter, but also by transductal pressure gradient, viscosity, ductal length. Now, one of the arguments is that diameter potentially is the major determinant, or is it? We assume that the ductus is circular in cross-section and cylindrical in its length. Here are some snapshot pictures of a series of shunts that we commonly see in the NICU. In some situations, the ductus is a classic cylindrical vessel, which is straight through. In others, it takes the shape of a watering can. I apologize, the red flow is what you should be focusing on here, which is the ductal gent. There may be some that look like a serpentine and some that look like a funnel. So the architecture of the ductus is highly variable. And this may be driven by genetics, and we know very little about how genetics modulate ductal closure or how they potentially may modulate response to treatment. But if we're to think about flow, if we're to think about treatment effect, we absolutely cannot do it without considering the fundamental structure of the ductus. What about clinical assessment? Well, here's a study by the UK group, Pereira et al., who looked at the relationship between clinical signs in the first week of life in extremely low birth weight infants and looked at what parameters predict a high volume ductal shunt. And what they found was that the things that we routinely look at, heart rate, blood pressure, heart murmur, do not predict a significant shunt. What did most consistently in this study was the presence of significant metabolic acidosis, which makes total sense. If you think about the physiological disturbances of a high-volume shunt, the ductus is no different to truncus arteriosus or even hypoplastic left heart in its physiology. So in 2007, we proposed that we need to elevate the bar to a degree of sophistication that moves beyond just looking at diameter, but looks at the amount of flow going across the ductus. And to do this, you need to provide detailed, thoughtful assessments, not just of size and architecture, but can we evaluate the degree of pulmonary overcirculation? Can we evaluate the compromise to the systemic circulation? And finally, can we exclude out situations in which the ductus has a beneficial role? The fundamental question is, what is the evidence that modifying the ductus will improve deranged physiology? The problem we have is that there are some morbidities which are associated with the ductus that occur early: IVH, pulmonary hemorrhage. Necrotizing enterocolitis occurs over a much broader span, and chronic lung disease may start at the beginning but may take many, many weeks before it's very clear. The challenge when you're designing trials is that there are many competing confounders during this same time point. Infection, the presence of NEC and so forth, that make it very, very difficult. So what evidence do we have of early intervention? Well, my esteemed colleague on the left has published very clearly that prophylactic indomethacin decreases severe IVH, decreases PDA ligation. We also know that both of these endpoints are associated with poor neurological outcome. However, the trial did not show an improvement in long-term neurodevelopmental outcome. How do we reconcile this inconsistency? Well, is there evidence of the association to very bad things from other venues? This is the Danish cohort study that was published by Anna Selmar that we were involved with several years ago, which shows that the presence of a large PDA on day 3 of life was associated with a 2-fold increase in mortality and a 6-fold increase in the incidence of severe IVH.